Wel, goedemiddag dames en heren. Ik vind het heel mooi dat ik heb de kans om jullie te ontmoeten vandaag. Toen ik was 5 jaar oud heb ik voor 1 jaar gewoond in Rotterdam. En Nederlands was de eerste taal van ons huis. Helaas is er niet veel kans op Nederlands te gebruiken in Canada. So het spijt me dat ik moet mijn presentatie in Engels doen. Ik hoop wel dat ik jullie iets bijpraat zal geven met deze presentatie. If I say more, I'm going to get very confused and I won't be able to focus on my own presentation. So anyways, have to do... Thank you. So what I'd like to do is to talk about quality across the continuum of care and to show you how we use the NedRAI instruments in Canada. We've heard a lot today about the various benefits of using these instruments. I'd like to show you some real-life examples of what we do with these instruments in my country. So I'll talk a little bit about these instruments in Canada and use a specific example of how we've been reducing use of antipsychotics across the country, and maybe end with some lessons that we've learned from our experience in the last several years. So this is my schematic of the representation of the use of these instruments across the country. And you can really see it's now at a national scope where we're using multiple instruments. The red dots are the nursing home instrument, the blue squares are the home care instrument, the stars are the mental health instruments. We have children's instruments being mandated, palliative care instruments. Really the full suite of NedRAI instruments are either being used for research or national implementation across these different provinces. A major partner for us is the Canadian Institute for Health Information. They have 3 reporting systems. One reporting system is focused specifically on the nursing home and post-acute hospital sector. So they take the RAI 2.0 and the NedRAI long-term care facility instrument from across the country. Their home care reporting system takes the NedRAI home care, the RAI home care, and the NedRAI contact assessment from across the country. And the mental health reporting system now implements the community mental health instrument, the adult inpatient psychiatry instrument, and the new child and youth mental health instruments. So CIHI, as they're known, is an extremely important partner for us. To give you a sense of the volume of the data that we now have, just thinking about these 3 reporting systems that I've just mentioned, we have over 9.6 million NedRAI assessments from over 1,800 organizations and 3.3 million unique individuals. So it's very large data. We often talk about big data. Well, these are big data and they're wide data, so there's a wealth of information that we can take a look at. Each year, there's about 600,000 new assessments added to the data. So we have real-time population-level data in these different sectors of the health system. What we can do with that is we can start to understand the distribution of clinical characteristics across the continuum of care. So what we did here is we looked at the cognitive performance scale, which Henriette talked about in the comparison of the shelter and IBank populations. So 0 is cognitively intact, 6 is severely cognitively impaired. And you can see we're comparing all adult inpatient psychiatry, palliative care, community mental health services, community social support services, home care, psychiatry for adults over 65, post-acute hospitals, geriatric psychiatry services, and nursing homes, all with the exact same scale across these care settings. And what you notice is that people who are cognitively intact tend to be more likely to be in community-based settings, and people who are very severely cognitively impaired tend to be more in institutional settings. That kind of makes sense, that if you're cognitively intact, you should be able to stay at home, but if you have very severe dementia, it's not surprising that you'd end up in a nursing home. But there's some interesting subgroups here that you may want to think about. So these are people who are in home care, who are in the second most severe category of cognitive impairment. Well, what are their caregivers experiencing? And what service needs do they have? And what's their risk of ending up in a nursing home? And then we have people back here in this corner. That's about 20% of the nursing home population is cognitively intact. Well, why are they there? Why could they not be in a supportive housing environment directing their own care? So even though the system looks reasonably rational, we can think about ways to fine-tune the system to shape it a bit better, to better service to match the service needs that people have across this continuum of care. So let's think about the specific issue of antipsychotic use. It's gotten a lot of press in the Canadian context, and I also noticed it's something that people in the Netherlands talk about. And Henriette, I think I remember it was about 25 to 30% use in the iBank data in the Netherlands? About 25% is the Dutch use from the iBank study. So what do we know about antipsychotic use? Most people now agree that we should use these drugs with caution, and there's a great deal of evidence about bad side effects related to those drugs. But there are some conditions that make it perfectly reasonable to use an antipsychotic. If somebody has schizophrenia, these are good medications. They should be used in that context. Where there's less agreement is whether we should use antipsychotics to manage behavior disturbance in persons with dementia. There's lots of evidence that this is a bad off-label use, and lots of people say we shouldn't be doing it at all. But in some cases, clinicians would argue that it might be reasonable to use antipsychotics to manage behavior. And the question is, how many of those cases? What's the frequency where it may be justifiable versus not? And that's where benchmarking, I think, becomes useful. First thing I want to show you is a study that we've just done on the use of antipsychotics in relation to psychosis and behavior disturbance in 4 different care settings. So first of all, we have home care. Then we have acute hospital patients awaiting placement into nursing home. Then we have post-acute hospital settings and nursing home settings. The green bar is people who have neither psychosis nor behavioral symptoms. The blue bar is people who have behavior disturbance only. The orange or beigey bar is people who have psychosis only, and then red is people who have both psychosis and behavioral issues. A couple interesting things you see here. First of all, when you have those mental health symptoms, use of antipsychotics goes up. So people who've got both psychosis and behavioral symptoms are the highest uses of it. But there's also some interesting differences that, we have 15% of home care clients who have neither of those symptoms present, but they're on antipsychotics. In acute hospital, it goes up to 30%, in nursing homes, it's around 25%. Also, I think there's some interesting patterns here in terms of what happens across the system. Now, these are cross-sectional data. We didn't follow individuals in this graph, but you'll notice that as you go from home care to acute care, generally antipsychotic use is going up. It would be reasonable to guess that there was a delirium and maybe that's why the antipsychotic was used. But then when some people make that transition into post-acute hospital cares, antipsychotics are still being used at a higher rate than we see in home care. And by the time we get to nursing homes, they're still persisting. And in the case of people with behavioral issues, the rates are about the same. So one of the things that might happen is that antipsychotics get accumulated over the journey through the health system, starting in home care and then going in to acute care. And so thinking about a systems-based approach to how we deal with antipsychotics is probably going to be an important thing for us to do. So this is a reporting system that the Canadian Institute for Health Information runs. If you have internet access now, you could type in yourhealthsystem.cihi.ca and you could get onto the website live right from here, no problem. What I'm showing you is a report from Holland Christian Homes. My late father, about 6 months ago, said to me, there may be a time where I'm going to need a nursing home, and I'm thinking I may want to go to the Holland Christian Homes because, there are Dutch people there, and they belong to the church I go to. So I said, well, let's take a look at Holland Christian Homes. So we did. And what you can see is about 60% of the residents are over 65, about 2% are under 65, about 2/3 are females, almost 3/4 have dementia, and about 11% have heart failure. It's a fairly typical type of home. And so then we said, well, let's look at antipsychotic use and restraint use. And so what we have is the rate for this specific home of Holland Christian Homes, the chain rate for all the Holland Christian Homes, the rate in the geographic region where those homes are located, the Ontario rate in the province, and the national rate. So actually, when it came to antipsychotic use, they're not doing too bad. They're about the same as the national rate, maybe a bit higher than the Ontario rate, but not too horrible in that regard. But when it came to physical restraint use, they were double the national rate, 14%, compared to 7%. In their local area, the rate was 2%, so they're 7 times higher, the rate of physical restraint in the area where they lived in those homes. So my dad said, well, maybe let's take a look at some other places. And we did start to talk about some other options. We can also see what's happening across the country. So these are 3 of the biggest provinces that have been submitting the most data for the longest time: British Columbia, Alberta, and Quebec, and Ontario, where I live. And what you see is that the rate of inappropriate antipsychotic use, this is where you're using antipsychotics and there's no indication of diagnosis of psychosis or symptoms of psychosis. The rates of those antipsychotics has been dropping. It used to be 35% in British Columbia. In Alberta, it was around 26%. But you see in each part of the country, those rates have been dropping. So we're seeing a decline in the use of these medications nationally because the nursing home industry was getting upset by all the attacks that were coming at them from the media. Then I became involved with a pan-Canadian intervention study to try to further drive down antipsychotic use. This was with the Canadian Foundation for Healthcare Improvement. It's a national agency focused on interventions for improving healthcare. And they wanted to do something on a national basis around antipsychotic use. So what they did is they set up a mentorship program for nursing homes to teach them how to think about dealing with antipsychotics, to support team building and team-based initiatives for reducing antipsychotic use. But they left it to the home to decide what specific thing they were going to do. Were they just going to stop everybody who was on the antipsychotics? Were they going to do an educational intervention? Were they going to use some other combination of approaches with it? They left a specific change to do up to the home. They just supported them in thinking about doing something and measuring it with the systems that they had. An important criterion was you were only allowed to participate if your home was using NedRAI assessments. If not, you were not eligible because you could not be measured against the national standards. And so we were able to link these data to those millions of national assessment records to see what happened in those homes compared to other homes in the country. Because remember, an important challenge from an evaluation point of view is the country's on a decline trajectory anyway. Rates are going down, and now we're doing an intervention study to try to drive the rates down even further. So these are the results. These are the homes that participated in the CIHI initiative, and these were the other homes in the country. So the sample size here, just so we're clear, is well over 1.5 million observations in 1,500 homes. So in the CIHI homes, what we're showing here is the median rate, the 75th and 25th percentiles, and the 20th and 80th percentiles. And what you can see is a pretty clear trend of reduction of antipsychotic use over time. There's also a reduction, though, in the rest of the country. But what you should notice is that that reduction was steeper. The participating homes were actually not the best homes that you sometimes get, but some of these homes were not so good compared to national standards. A simpler way to understand this is to compare the different points in this distribution. So if we think about the 20th percentile, these are the best homes. The 80th percentile are the worst homes, and the dot in the middle of the median are sort of the average homes, for want of a better term. What we see is that for every type of home, the reduction in the intervention homes was greater than the reduction that was happening in the country overall. So for the best homes, it was double the reduction. For the middle homes, it was a little bit less than double, but still a higher reduction. And for the worst homes, it was more than double the reduction. So at every point in that distribution, there was an improvement, a bigger improvement in the intervention than compared to the control homes. And also, by the time the study was done, all the intervention homes had a rate that was at or below the rate of the rest of the country. So from their point of view, they thought this was pretty successful. When we did a multivariate, multi-level analysis for this, we found the odds of staying on an antipsychotic in the intervention homes was about 20% lower than the pattern that we were seeing in the overall country. So if I was to think about the last many years that we've been implementing NedRAI instruments, I think there's a few key things that we've learned that I can tell you about. The first of all is it is possible to do this on a large-scale basis. What you may not know about Canada is that we're a federation. Each province is responsible for managing its own health system and sets its own policy. So we didn't just implement this nationally in Canada, it's the equivalent to implementing this nationally in 13 countries, because we have 10 provinces that are independent, 3 territories, and the federal government runs its own system as well. So that was a pretty challenging implementation to have happen. We also found very quickly that you could use this to help multiple audiences in many ways. Funders can use it, quality advisors can use it, government can use it for planning, advocacy groups can benefit from it, but most importantly, clinicians and the persons being assessed can benefit from it as well. Although that last implementation or that last benefit is something you have to work at. It doesn't just come automatically. You actually have to focus on engaging the person and the family in conversations. And so what it really does is give us a new evidence base for discussions that we want to have in our country to say, how can we change clinical practice to make things better? How should we change services in order to reduce unnecessarily institutionalization, for example? What key policy should we put in place? We just used NedRAI data to increase a substantial amount of funding to the home care system. And advocacy groups can also use it to advocate for the needs of vulnerable persons. It's certainly the case that when you introduce these systems, you can increase accountability in your health system. Any nursing home in English language Canada, you can go online and find them and find out about their quality rates. Some provinces are a little bit behind because they've just started implementation, but certainly in Ontario, where there's 800 homes, you can do what I did and find the performance of a local home. And what we get then is that we can improve care at the person level, and we could do it at the system level with the same system. So with that, I'll thank you for your time and attention.